Topic is breaking the deadliest of all formation of the complex cataract with innovative surgical techniques. And I would request Dr. Binod Arora, our first speaker. He's going to talk on a small pupil phacosurgery, tricks and tips.
Good morning and a warm welcome to India. I think after a hefty night and very heady night, most of the people are just in slumber now. Still, we will start the meeting. And without waiting for others to come, because we have to stick to the time also. So, a small pupil is a big problem in cataract surgery. So, what is a small pupil? It is 2 millimeters, 3 millimeters, 4 millimeter, what we call it as a small pupil. So pupil, small size is related to surgeon's skill and technique, intraoperative situations, properties of iris tissue and pupil. Suppose there is a soft cataract, it may not be small pupil for many person. But for a hard cataract, you need a bigger pupil. So it's a relative term and depends on various things like surgical skills, intraoperative situations, and properties of iris and tissue pupil. ये थोड़ा सा डिस्प्ले इधर का देना हाँ चेंज करना है विनोद अरोड़ा So again, a small pupil and a big problem. So what is small pupil? It depends on various things. It depends on the surgical skill and technique. A good surgeon can do even if they smaller pupil, but for a novice, a big pupil is a mandatory. Then intraoperative situations like cataract may be soft or cataract may be hard or there may be some complications. So some of the cataracts can be managed with even with a small pupil like softer cataracts. But most of the things require a reasonable size of pupil. Then properties of iris and tissue. There is a iris tissues coming out, and it's a floppy iris or something. We require again a bigger tissue, bigger pupil. Coming to the surgical skills and technique, there are various pharmacological agents which has been used to dilate, like tropicamide, cyclopentylate, and NSAIDs. Then we can do viscometriasis with putting a heel on, soft shell technique or disco whisk. Then pupil can be stretched and it sometimes remains dilated. Like elastic pupil, we have to confirm whether it's elastic pupil or it's a rigid pupil. If we try to stretch rigid pupil too much, it may break the sphincters. But elastic pupil can be stretched, the only thing it will come back again. Rigid pupil can be stretched a little bit and it remains there. Then in some cases, sphincterotomy can be done. For rigid, non-dilated pupil, we can just make a small nicks on the pupil. So that makes the surgery much easy. Then in the phaco, we have to follow the low fluid parameters. And we have to chop the thing. We have to use a vertical chop that makes things much easier. Doing a horizontal chop is difficult in these cases. Restrict manipulation to pupillary area. And bimanual IA helps in these cases. So what is the problem with a small or non-dilatic or poorly dilated pupil? There is a reduced surgical space and we have to make then a small capsular axis. There is less visibility of the peripheral of the lens. This causes iris prolapse. There may be retained cortical matter in the peripheral capsular bag which we can't see. There are one haptic of the IL in the capsular bag and other may be in the sulcus. We are not very sure where we have placed it because we can't see it directly. Then there is an increased post-operative inflammation, corneal edema and CME because of too much of manipulation of the iris. So what can be done in these cases? So we have to, before going surgery, we have to remember that any eye can have IFS. There is no telltale sign, so any eye can have IFS. We should be prepared for that. So we should reduce threshold for using pupil expansion devices. We should keep it ready with our OT. And these releases we have to release the posterior synecdoche and peripheral membrane completely. Intracameral injection of the combination of mediatics and local anesthetic can be used for these things. Dr. Satanshu, please. Test and distinguish the elastic from non-elastic rigid pupil. Unlike with non-elastic pupil, the IFS pupil immediately snaps back and to its original size following attempt to stretch it. You can't stretch it. So what are the things which we can use during surgery? IRIS-6 are very, very popular now, and most of us are using already it. So there are some tips once you are using a iris hooks. You can go through as a very small incision like 0.5 millimeter. You can make mark on the limbus before putting the iris hooks. That makes the thing much easier, and it can be placed. A hook should be planned well in advance if it is to be placed at the phaco incision. Then the incision should be limbal. There is a stopper end. Hold the stopper and you can rotate the iris hook to the desired position. And utilizing the tented portion, we just stretch it and slightly it comes out. Then over retraction and asymptomatic retraction the hooks to be avoided. You have to make a symmetric one, so the pupil remains dilated throughout and you get an equal area to just expose, and don't overstretch it, otherwise the pupillary sphincter will be damaged, and once you finish the surgery, it will not come to back its original position. And you can use even after capsule access, but you have to be very careful, especially in the deep set eyes, and removal is slightly tricky. You have to learn it, how to remove it. Otherwise, if in difficulty, you can take it from the main incision also. Then there are various devices which can expand the pupil. I'll not cover all of them because there is a very long list, but I'll be covering some of this. This is AIOS pupil expander. There's no intraocular manipulation. It's a very fast, easy and safe positioning and removal. Efficient iris expansion. Minimum incision size 1.1 millimeter, that's from the 19 gauge you can put it. It's made from nylon.
The APX is a device designed to mechanically dilate a small pupil. A set of 2 expanders and 2 designated disposable forceps are supplied in a sterile blister package. The forceps tips are inserted through the slit in the base to grasp the outer segments of the APX. The loaded forceps are then locked and placed on the table until needed. 2 19-gauge side port stab incisions are made parallel to the iris plane opposite to each other. A cohesive ophthalmic viscosurgical device is injected to fill the anterior chamber and raise the pupil. The APX device is inserted through the stab incision until the pivot is within the incision. The terminal tips are then positioned behind the iris sphincter one at a time, and the forceps are slowly released until the APX device fully expands. The same procedure is done on the opposite side. Note that no intraocular manipulations are required to position the APX and dilate the pupil. Capsulorhexis and phacoemulsification are performed in a conventional fashion by direct visualization through the widely dilated pupil. Removal of the APX is done using the same designated forceps in a reverse fashion. The device is simply closed and removed in a matter of a few seconds. Again, please note that no intraocular manipulations are required also for the removal of the APX.
So these are very tiny, and the beauty is you don't require any intraocular manipulation. You don't have to put a second instrument inside the chamber. It's not required. All it is dilating too much. If you feel like you can put another one, but I don't think it's required, because you got a good square opening there in the pupil. Then there's another device that's the iron pupil expander. This has to be injected come with injector. Basically, the principle is not to cause damage to the sphincter. So these all should be very gentle to the pupil. Now you see it's easy, but only thing you have to put a second instrument, you have to stretch a bit. a very special tip is always just do stretching before putting any expander. Stretch a pupil little bit, then put your expander, not directly stretch. That helps to dilate the pupil properly and you can easily put it. And you have to use a lot of viscoelastic in these to avoid damage to the surrounding structures. So it's made of ring material polyurethane. It's a soft, resilient material that's gentle on the intraocular tissue, and fixed channel height does not compress the pinch iris during the session. It's completely 360-degree engages the iris and eliminates distinct stress point. There's no points as such. And it gives a good 6.3 millimeter circular area to do operation. So it's make the life very easy. Then Maillon ring is probably one of the most popular internationally also. It can go through 2 millimeter incision, that means from the main port, and it's a gentle expansion. There are 8 points of contact. You require a high viscosity, I think that's required for everyone. And Oshoro Maillon ring manipulation is a classic one.
This is Dr. Kachikian from the Eye Institute, and what you're seeing here is the early part of a cataract surgery with a small pupil. The device we are placing here is called a Maillon ring, and we use this ring to expand the pupil to allow us to access the cataract and remove the lens safely. Each eyelet of the ring hooks onto the iris and holds it out of place so we can do the procedure. As you can see here, once we get the last eyelet hooked on the iris is retracted very well. Placing the Maillon ring in general is minimally traumatic, and removing the ring is fairly easy as well. So it's an excellent solution to a small pupil.
I'll take 1 minute. So this is our Indian version, again an international product, BX pupillary expander. A third generation Bhattacharjee ring. It's a flexible, jointless, hexagonal polymer ring, thin with 6.5 and 0.3 millimeter profile. It's a very thin one, and it has a single plane. You get a 5.5 millimeter pupillary expanded. And now we have got BX 2.0, the newer one, which is big and strong. It slightly thicker, 675 millimeter, and it's good for rigid pupil.
The B-Hex has redefined pupil expansion. Patented uniplanar hexagonal design with notches and flanges. It is 1/10 the thickness of other devices. A 23-gauge forceps advances the preloaded device from its transparent housing through the incision into the eye. As alternate flanges are tucked under the iris, the notches engage the pupil margin, resulting in an expanded pupil. Removal is so much easier than other devices that it can exit even through a 1 millimeter side port incision. And we have a wonderful round pupil at the end of surgery. This is an advantage in femtosecond laser assisted cataract surgery, where it helps maintain a well-formed anterior chamber during docking. The unique advantages are a disruptive uniplanar design, the hexagonal shape, an injector-free delivery system, and a preloaded device in a transparent housing.
I can just sum up that we have capsular hooks also, iris hook also, and we have got the expanded devices. All work well for the beginners. Start with the iris hooks. Once you get it comfortable with them, then try this one, because it requires the intraocular manipulation. Once you are comfortable, you can use pupillary expander. They causes less damage to the pupil compared to the iris hook, and they are now very, very cheap, available in India also. Earlier the cost was a factor. Now it's very cheap, and local products are very, very good. Thank you very much.
Thank you very much, Dr. Vinod, for the wonderful presentation. And now you have so many options of pupil expander available. And but I think still a lot of people use iris hooks, which is more comfortable, reasonable, and cost-wise. And Dr. Vinod, like you spoke all about this expander, do you try to use like ferrocane or pupil dilator first and then go for the expander?
Yeah. Basically, if you use a tropicamide before the procedure, so usually these phenocane or things hardly works. But still, it's better to give a choice to intracameral tropicamide or lignocaine combination.
Yeah.
Sometimes it works in few people, but if you have already used tropicamide earlier, tropicamide plus, so it hardly works that cases, or those cases.
And secondly, availability of Malaysian ring is now getting a little difficult because there is some problem with the import of the Malaysian ring now, all over the world.
But now we have got a lot of Indian rings also. There's a Gupta ring, that's again a very good one. Then Bhattacharya ring is definitely is a very, very good one. I think these all works well and the cost is not a factor. They cost you around less than 2,000 rupees. So,
Anurag, you be ready with your...
I think
yes, sir, yes.
Anybody can use it. Cost is not a big factor.
Right.
Because you are not using it regularly. It's required in few cases.
Yeah. Take the mic,
Price?
Madhu, iris retractor we know. First, we showed one, first one, that two, I asked the question 3. We can
yeah.
What is the company, what is the price, sir?
It's around 1,600 rupees, Madhu's, Gupta's ring.
Oh, that is Gupta's.
That makes a square pupil. It's a 4-point contact. It's again a very good ring.
It is marketed by Madhu only.
Madhu only.
Newer one, thank you.
Yes, sir, you wanted to ask something?
Actually, scenario of cataract surgery is very fascinating. The old school of thought that move the digital cataract surgery away from correcting it. I have seen right from the pseudosurgeons who are called as coutures and couching to the present state. One of the promise of the surgery is the cataract, which is done by each and everything before the subspecialty. Now, in the pre-surgical area, when there are basically these coutures, they would do the couch, they put together the needle, the limbus, disloding the layers of the patient. That case I have seen in 72 when I was a resident in RP Center. And then came the technique of what you call as the Van Griffiths cataract knife, making a section and removing the lens by Aroga's extra planed first. And then came the technique of removing the lens by erysophagic, Dastur's erysophagic.
Yes.
And then tumbling, Symmetrian technique. Then by syringe.
ECC and then
came by what you call as vectus. Then cryo. Then came the technique of anti-chamber IOL. Post-chamber IOL. Then came phaco. And still it's going on.
Even femto, no.
Still the thing is that still we have got a lot of backlog of cataract.
That's right.
And at the far off places, it is done by the eye camps.
That's right. That's right. Thank you, sir. Thank you very much. Now we have the second speaker, Dr. Anurag Badhani, and he's going to talk on pre-nuclear emulsification PCR. How do I manage? He's a retina surgeon, but he's going to talk on a small talk on cataract.
Good morning, everyone. So
Dr.
in
Tamir,
this presentation, we will go through a series of videos, and here we will try to learn how to manage PCR in different situations. So PCR is a well-known complication of cataract surgery. It's a dreaded, potentially vision-threatening complication, and it may call for additional surgical procedures in the same sitting or in the next 1 or 2 sittings, and higher incidence of post-operative complications is also there associated with PCR, which may finally affect visual outcomes. So the strategy in such cases is mainly to recognize the tear as early as possible. There are some signs like sudden deepening of the anterior chamber, some sudden change in pupil size, especially during hydrodissection, which is called the snap sign, where there is pupil constriction, and abnormal tilting of the nucleus, abnormal behavior of the nucleus following the phaco-tip. These signs can help us recognize that there is a tear earlier, and in such cases then we should stop immediately. We should stop aspirating, and the phacoemulsification should also be stopped. We should continue irrigation in such cases and inject visco and form the anterior chamber immediately, and then stabilize the chamber and the tear by various techniques before it becomes larger and causes more complications. So this is a case of a mature hard cataract. While aspirating the final few fragments, we see that we have created inadvertently a posterior capsular tear. So here we immediately stop and put lots of visco, form the chamber, mainly to move the fragments away from the tear and push the vitreous back. Here we are attempting a posterior capsular excess to regularize the margins of the tear so that the tear does not extend towards the equator, and by completing the rexis, the implantation of IOL becomes even easier, because here we could complete the posterior rexis. We are going forward with the plan of implanting the multifocal IOL. In this case, we carefully implant the IOL in the bag, and here in this case the IOL also helps to scaffold, it acts as a scaffold to hold the vitreous back, and also as a base to emulsify the rest of the fragments without loss of any fragment into the vitreous. So here we were able to complete the case with good visual outcomes. Of course, we have to ensure that there is no vitreous in the AC by staining with the triamcinolone crystals. This is another case where the pupil was very small, and while emulsifying the fragment, we saw that there was the fragment was going behind and behaving abnormally. So we again put lots of viscoelastic, and also in these cases we have to put visco under the fragments, and preferably bring the fragment in the above the iris, and inject lots of visco in the retrocapsular space also, so that the vitreous falls back. So here again we are attempting scaffolding the tear with the IOL. We are placing the IOL here in the sulcus, and the fragment is then under the fragment. We carefully place the lagging haptic in the sulcus first. Now we can easily emulsify the remaining nuclear fragments without chances of loss in the vitreous. So these steps can be performed only when you're sure that there is no vitreous prolapse already happening, because if there is vitreous in the AC, then we cannot attempt these steps. So another case of an intumescent white cataract, where Argentinian flag sign is a known complication. There is a sudden radial extension of the initial prick on the capsule. So in such cases, again, we do not need to panic. We can attempt to create a round capsular excess from the tear, so that during the rest of the steps during cataract surgery, there is less chances of extension of the tear post-equatorially into the posterior capsule. The trick is doing phaco very slowly with slow parameters, but as this was a soft cataract, during attempting to chop, we realized that there was a double trouble in this case. We also created a posterior capsular tear here, and we realized it in time. We removed the nuclear fragments, and the rest of the cortical fragments we attempted to remove them through the main incision. So key step is to continue irrigating and put lots of viscoelastic, preferably dispersive. And here you can see we are pulling out the fragments one by one directly out through the main port. Then we complete vitrectomy. Here we are using the irrigation cut aspiration mode, and bimanual vitrectomy, where we use a separate irrigation, is a preferable option in these cases, but we had the coaxial one in this case. Then we complete the removal of rest of the cortical fragments. Without much loss into the vitreous. We ensure there is no more vitreous around the tear and in the above the iris and near the ports. So we cut from posterior to anterior, and then forming the anterior chamber again, we were able to place the IOL here. So all the time we cannot have such positive results. So this was a very hard cataract, and while attempting chopping of the nucleus, we realized that there was a pre-existing, or this PCR was created during hydrodissection, and the nucleus was almost slipping down into the vitreous. We levitated it with MVR, brought it into the above the iris, and attempted to fragment it, converted into an ECC. We expressed the nuclear fragments one by one. Then with partial closure of the incision, following which we started anterior vitrectomy, ensured there are no vitreous strands in the AC. And then we implanted a 3-piece IOL. Here we are, because there was a good anterior capsular support, we are attempting to implant it into the sulcus. So carefully sliding the leading haptic first inside, ensuring that it is in the sulcus, then we can slide the rest of the lens. Placing the optic under the iris and then gently rotating the lens into the sulcus. So in cases where none of these methods work and you end up with a posteriorly dislocated lens, then we have to refer it to a VR surgeon. So here I'm showing a video where we free the lens from the vitreous around it. We need to do a good vitrectomy first, and then extend one of these sclerotomies by a 20 gauge MVR to allow the phacophragmatome to go inside the vitreous. Here we have also injected a PFCL bubble over the macula to protect the macula from phaco energy damage and also from manipulation of the lens fragments over the macula. And in the same sitting or in subsequent sittings, we can put a secondary IOL. Like here we are placing scleral fixated IOL, the CMT Flex. So recently I have shifted all my secondary IOLs to CMT Flex because of the ease of handling the lens. It's a quick procedure and the centration is also very good. So the second haptic comes out, and then we can seal these scleral flaps through glue, or we can also suture it. We can also implant iris fixated IOLs either in the anterior chamber or like in this one, we can fixate it posteriorly as well, behind the iris. So the key points are that we have to identify the tear as early as possible and start a stepwise approach. Managing vitreous is most important to avoid posterior segment complications, and IOL implant should be attempted only if good capsular support is there, and refer to the VR surgeon as wherever it seems necessary. Thank you.
Thank you very much, Dr. Anurag, for the wonderful presentation. And this is the gambit of different videos which we have shown, different situations you can come across in your clinical practice. And posterior capsular rent is one of the very serious complications which we can come across during our cataract surgery, phaco surgery. And how you manage the posterior capsular rent is very important, because it's not like we do not get the posterior capsular rent, we all get the posterior capsular rent. But how you manage it is very important, because you can give a 100% result to the patient even after the posterior capsular rent. And Dr. Bharti?
Yes, sir.
Yes, sir. Mobile chhod do. Any comment?
I think he has actually dealt with both the posterior capsular rent and the flag sign, Argentinian flag sign, very well. And the most important thing is to manage it, do not panic, and be peaceful at your mind, so that there is, you are not in a hurry to do it, and then probably in all the cases you will be able to manage it. Whatever is there, I think it can be managed. We are all very experienced cataract surgeons, so these are the small issues which keep on coming in. All the surgeons, all of us face these issues. So I think the most important thing is keep your peace in the mind, and that probably is the crux of the matter.
Thank you, sir.
I think again, first thing is you have to recognize it early.
Yeah.
So early recognition helps you a lot. Even the flutter sign is very good. If you are showing the white mature cataract, the flutter sign is very good. You can know whether it's extended to posterior side or not. So you can continue or not to continue, you can decide with that one. And of course the tamponade with visco and even with the lens is a very, very good option in these cases. You have shown it beautifully. Okay. So whenever you get it, first thing you have to relax and take your time, pray in all languages if possible, and then start your next step. The visco, putting a visco is immediately, I think that's the most important thing, what he has shown as there. Put the visco immediately, and then take your time and start what you want to, how you are going to manage these cases. Excellent presentation.
Depending on the demands of the patient, we have a few old patients who have undergone aphakic cataract surgery many years back. So we have some patients who usually come for a secondary IOL. So visual act, definitely, because the patients who are dependent on aphakic glasses, when they get freedom from that, then definitely it gives a good visual outcome. Secondary IOL. In some very old surgeries where before pre-phaco times, there is in some patients where there's an iris loss, or there's a very high astigmatism, corneal astigmatism. Yes, few patients, especially to remove the remnants of the capsular bag, because otherwise the secondary eye will not center properly.
Thank you very much. And now we'll go on to the next talk. Our guest talk, and it's a keynote address by Dr. Tamer El Ragal. He's from Egypt. Dr. Tamer is a professor of ophthalmology in Shams University of Cornea and Refractive Surgery. He's also consultant to Watani Eye Hospital. He's an elected board member of EOS, and he's also a board member of DEOS, board member of ESOIRS. So he's a very well-known ophthalmologist in Egypt and internationally also. And today we are going to hear from him, and he's going to talk on cataract procedure with previous refractive surgery. So Dr. Tamer Algar.
Thank you very much, Mr. Chairman, Mr. Co-Chairman, and I'm very glad to be with you in this prestigious conference. I'm going to talk today about the cataract surgery with previous refractive surgery. As we all know, the refractive surgery is either corneal or lenticular. And the LASIK was FDA approved in 1998. This means it's now 27 years ago. So we have large number of patients currently ready for cataract surgery or will be in the coming years. The concern in the post-LASIK eyes or post-corneal refractive surgery eyes is the high expectation of the patients, difficulty in IOL calculation, IOL selection for these patients, and the visual quality post-operatively, and the ocular surface problems in the previous refractive surgery. So, our patients having early refractive surgery are seeking early cataract surgery because they need perfect vision, demanding refractive cataract result as LASIK. So they are needing spectacle independence and asking for the latest IOLs to get rid of all glasses. They accept enhancement because they are very brave, and you have to set realistic expectations for these patients. The second most important difficulty is the IOL calculation. And the error in the IOL calculation is related to the instruments we are using, the formula we are using, and the refractive error index. We have many methods for calculation, and we have the problem mainly related to the previous cornea refractive surgery, related to the K reading, which is not the true K reading, and the effective lens position, which is the distance between the anterior surface of the cornea and the intraocular lens. We have many formulas used for these post-refractive surgery eyes, but the easiest method is to use the ASCRS calculator, which is free of charge. You can go through the website and you can enter the patient data regarding the corneal power and the axial length, anterior chamber depth, everything. If you have the history before the corneal refractive surgery, which is not the usual case, you can add. And at the end, you can get formulas that can be used in your IOL master, whatever the machine you are using. You can use the formula anterior segment OCT or Higgins L, Barrett through K, and Muscat. These are the most useful formulas or the most accurate formulas in post-corneal refractive surgery eyes. And you can take the mean value of these formulas, and if you have a wide range, choose the highest IOL power. Also, we have now the European Society Cataract Refractive Surgeon calculator. Again, it's free of charge. The IOL selection, according to the previous refractive surgery, you have to do a pentacam or topography to know the previous refractive surgery, either myopic, astigmatic, or hyperopic. And if you have myopic LASIK before, that means that you have an oblate cornea, and an oblate cornea with positive spherical aberration, you have to implant a negative spherical aberration IOL or negative aspheric IOL. For hyperopic LASIK, the opposite, we have a prolate cornea, or hyperprolate cornea, and you have to implant spherical or zero sphericity IOL. And these are example of the IOLs in the market. I have no financial interest. We can implant toric IOL, but provided you have a regular corneal astigmatism. And you can see this in this picture. If you have this patient with LASIK surgery or previous corneal refractive surgery, and you have central 3 millimeter regular astigmatism, you can implant. Although the appearance of the cornea is irregular, but still in the central 3 millimeter, it's more or less regular, you can implant a toric IOL. Never to do laser limbar relaxing incisions, because the preoperative assessment of the corneal astigmatism is less reliable than inversion eyes. What about the multifocal or extended depth of focus IOLs? Multifocal is not preferable, but extended depth of focus IOLs can be used in myopic LASIK, provided that you have a well-centered ablation, large optical zone, regular corneal astigmatism, pupil size is not that large scotopic pupil size, small angle kappa, and healthy ocular surface. And at the end, you can have an increased risk of dysphotopsias and higher order aberrations. But never place a multifocal intraocular lens in a patient with hyperopic LASIK, because this is a hyperopic LASIK or multifocal cornea. So multifocality in the cornea and of the lens can disaster the visual quality. Monovision is still a viable option in these patients. What about the post-operative visual quality if the patient is not satisfied? If you have irregular corneal astigmatism after surgery, after the phacoemulsification, due to decentered ablation or smoked optical zone, this is before the surgery, you can do two-step procedure. Number one, to enlarge the optical zone, or to centrate or center the laser ablation, and then after 3 months you can do more reliable IOL calculation. So you have to correct the corneal issue first and then do phacoemulsification afterwards. Many patients of the previous refractive surgery having OSD or ocular surface dysfunction, and this is very common after corneal refractive surgery. So we have unstable tear film with inaccurate K readings, and IOL calculation will be inaccurate also. So you have to optimize the ocular surface first. You have to treat the ocular surface dysfunction, and then you can have an accurate measurement of the IOL and accurate measurement of the refraction post-operative, and more smooth recovery and more wound healing properties. We can use combination of artificial tears. We can use lid scrubs, nutritional supplements, and sometimes IPL or thermal pulsations. The surgical technique is not that different from version eye, but you have to avoid the flap edge, so you have to have more posterior and more short tunnel, corneal tunnel. Take care, you are dealing with ametropic eyes, so you can have a deep or shallow anterior chamber according to the refractive state of this eye preoperatively. Intraoperative aberrometry, I don't have an experience, but it's not now popular at the time being. Post-operatively, you have to have more frequent follow-up visits. For fear of DLK, you can use steroids hourly, and then you have the usual tapering regimen. If you have you need enhancement post-operatively, you have to wait at least 2 to 3 months for stable refraction, and you have not to use topography-guided enhancement if you have toric IOL or sulcus fixated IOL, so you can induce some lenticular astigmatism. But you can use the wavefront optimized or even wavefront guided ablation for these patients. For radial keratotomy, now it's not that popular, but the surgical technique, you have to go with minimal size incision and not to encroach on the RK incision in between. If you have 16, you don't have the way to go through outside the incisions. If you have insufficient space, you can use clearer tunnel. And if the RK incisions are crossed, you can make 2 horizontal sutures with low flow phaco, and you have to aim for slight myopia because these patients having a hyperopic shift post-operatively. And sometimes the IC8 or the pinhole IOLs may be used in these cases. For the phakic IOLs, you have to use the formula for phakic eyes, not for the pseudophakic eyes, which is more accurate in these patients. You have to make sure that the endothelial count is good for the surgery, for the removal of the IOL, especially the anterior chamber IOL, because we have endothelial compromise for the long-standing IOLs in the anterior chamber, and during the surgery you are going to damage more endothelial cells, so make sure that the endothelium is healthy. If not, you can go for DMEC surgery with the cataract surgery. If you have ICL explanted, you can do the phaco through the same incision because it's foldable, as you all know. In case of anterior chamber phakic IOL, rigid or PMMA, you can explant the IOL through a scleral tunnel, superior scleral tunnel, and you can do the phaco through temporal incision. Laser enhancement might be required in these cases. To conclude, a vast majority of patients with previous refractive surgery are ready for cataract surgery nowadays. Multiple formulas developed to compensate for alterations in the corneal power, including the OCT and the Higgins L, Barrett through K, Mascot. Consider the best IOL option for each patient. The ocular surface dysfunction must be optimized before surgery, and patients must understand the possibility of refractive surprise and anticipate the need of enhancement. And thank you very much for your attention.
Thank you very much, Dr. Tamjid, for a wonderful presentation of post-LASIK cataract surgery, because you have explained each and everything, the IOL formula calculation and pre-op investigations and then the surgical procedure in all these cases. Because the most important thing what we see in post-refractive surgery, you should know that what refractive surgery was done. And if you have a history and if you have a record, then it becomes a little easier. If not, then you have to do a good pre-operative evaluation of the patient, which is very important in terms of pentacam, looking all the parameters of the eye, and then comes the IOL power calculation, which you very well explained on the surgical procedure. Thank you very much. Thank you. So we'll take up the discussion later because we are running short, I think, because we started late. Yes.
RK patients? No. I'm telling about the previous patients 40 years ago. We have patients now with cataract. You have to make sure that everything is ready during your surgery. Thank you very much.
Thank you, sir. Thank you so much. And now we have Professor Arvind Kumar Maurya. He is going to speak on intumescent cataract eminent to Argentinian flax and how to manage it. Meanwhile, Dr. Thimina, what's your choice of in myopia LASIK you told you choose minus negative spherical lenses. So which lens you prefer?
For myopic LASIK
For myopic LASIK.
you have to use an IOL with negative spherical aperture.
Which one you prefer?
For me, I use Technis IOL.
Technis has the highest negative sphericity. I think it should be used because of it says around 0.27.
Yes.
That's the highest negative sphericity.
Exactly.
This one.
Okay. Thank you.
Thank you, sir.
Good morning, esteemed chairpersons and my dear friends. So my talk is on intumescent cataract, that is eminent to Argentinian plaque sign, and how to manage it. And thank you, Terminator, for giving me the opportunity. Slides are not moving. So I have no financial interest in the subject matter. So this Argentinian flag sign is a self-propagating radial extension of the anterior capsular tear, and which typically arises instantly after an initial prick with a sharp hypodermic needle or a sharp tip rhexis forceps. So it was first described by the Perron. So it just looks like an Argentinian flag sign and is the most common complication for the intumescent white cataracts, as per this study. So the Perron described it to be the sequelae of a raised intralenticular pressure as the only factor responsible for the propagation of the initial prick into a radial capsular tear. But there are other factors also, from posterior to anterior compartment pressure, high pressure anterior compartment, propelling the posterior compartment, and also the forward thrust of nucleus is also observed. So there are various techniques available to neutralize raised intralenticular pressure and decompress the bag, like two-stage capsular access, mini rhexis, phaco-capsulotomy, precision pulse capsulotomy, puncture-access, Brazilian technique, and also now flax is coming up. So there is this small needle aspiration technique. It involves pricking the anterior capsule with a sharp 26 gauge hypodermic needle. That is followed by the simultaneous aspiration of liquefied lens matter to decompress the bag, and quite often peripheral extension of the capsular tear commences instantly after pricking the anterior capsule, even before the liquefied cortex aspiration is initiated. So there are many mechanics of the Argentinian flag sign, and so it means there had to be some other factors responsible which assist the raised intralenticular pressure to propagate the splitting of anterior capsular tear, resulting into the Argentinian flag sign. So this is a beautiful, wonderful study under the leadership of Rajendra Prasad sir, and it was published in JCRS. You can go through the whole article. It's freely available. So what is not known regarding the Argentinian flag sign? In reality, it's not the raised intralenticular pressure the only factor responsible for the extension of tear. It is the configuration of the initial puncture created to open up the anterior capsule by the sharp tip hypodermic needle or the rhexis forceps. So when we are puncturing the anterior capsule with an ultra sharp beveled hypodermic needle or sharp tip rhexis forceps, results into a small linear cut with open edges along the entry. So there is raised intralenticular pressure that triggers the disruptive forces along the discontinuous open edges of the linear cut. And so what is not known, that this linear cut easily opens up and it's rapidly radialized to the periphery, resulting into the Argentinian flag sign as seen in this animated video. And this tear always extends radially along the discontinuous open edges of the linear cut. It is never perpendicular to the tear. So we came up with the hypothesis that if we are able to manually create an opening in the anterior capsule which had a round and regular configuration instead of a linear cut, we may provide resistance against the disruptive forces, thus preventing Argentinian flag sign. So to open up the tense and stressed out anterior capsule, we designed and developed a novel instrument that is known as sieving needle microcapsulotome with a smooth round pointed tip similar to sieving machine needle system. So this round pointed tip, when puncture the anterior capsule, create an opening with a smooth and round configuration without any discontinuity. So these are the real-time videos. So there is a round hole microcapsulotomy with round regular configuration that provide greater resistance against the disruptive forces generated by the high intralengular pressure, and it also allows the liquefied lens matter to egress, thereby decompressing the bag without propagating a radial extension of tear. So after this round regular opening, the rhexis, the intended rhexis of 5.25 to 5.75 is easily achievable. And we also did a clinical trial when we compare this world's first such clinical trial between sieving needle microcapsulotomy versus the simple needle aspiration, and there was a significant p-value difference of 0.001. So it's a very effective technique and can be easily done by anyone. So for complete evacuation of fluid, multiple these punctures can also be created. So these 7 extension into the Argentinian flag sign using the simple needle aspiration, whereas only 1 extension was seen. And so in conclusion, in intumescent white cataract, it is primarily the linear cut configuration of the initial prick which has the potential to spontaneously extend along its open edges, leading to Argentinian flag sign. And the sieving needle microcapsulotomy with round regular configuration like a capsulotomy in true sense provides resistance against the disruptive forces that is triggered by the high intralengular pressure, and the initial decompression of the capsular bag facilitates safe and controlled creation of a capsular axis of an intended size with a higher level of efficiency and safety. Thank you so very much.
Thank you so much, and because we are running short, we'll keep the question answer in the last also. And now we have Dr. Sudhank Bharti, one of the renowned eye surgeon from Delhi, and he's one of the eye surgeons who started the refractive surgery very early, the earliest starter. Dr. Bharti is going to speak on post-RK cataract surgery management pearls. Dr. Bharti, please.
Thank you, Dr. Vinod, and thank you, Dr. Rajendra Prasad, for giving me this opportunity to be part of your instruction course today morning. And I am so delighted to see so many attendees, so many delegates coming so early in the morning to attend the sessions. I'll be talking on the cataract surgery after refractive surgery. I've been doing radial keratotomy since 1985-86 and did quite a number of cases before I started doing LASIK in 1995. So the topic is very exhaustive, and there are so many things which one has to discuss, but I'll be limiting myself to one of my videos here, which is radial keratotomy done almost 20 years back, and now a case of FLACS, the femtolaser assisted cataract surgery. You can see that the incision is opened. There is a stigmatism in this particular case. So I am going to put a toric techness IOL, because the techness is the best, as already discussed earlier in the question answer. And you can see that there is a very nice capsulotomy done by the laser, and the incisions, the cuts which are there because of the laser, they do not hamper the effect of the femtolaser in reaching the lens, so there is no defect in the capsulotomy, and there is no need to pull the capsulotomy out. It is already separated, as you can see, and then simple phacoemulsification. I do not normally do capsulotomy or capsular fragmentation with the femto laser, because I find that is sometimes goes deeper than what you expect, and that's not a very good idea. So I chop the lens myself. There are marks, and you can see that I have gone between the cuts for my major incisions, which is the advantage whether you're doing manually or with the femto laser. And once I have divided into multiple fragments the nucleus, I'll remove these fragments one by one. Very quickly they can be emulsified, because these in this particular case it is probably a grade 2+3 or 3+ cataract. And then removal of the epinucleus is not very difficult. The only thing which I wanted you to notice was that I rotated the nucleus so that there was no corticocapsular adhesions. These are removed very peacefully with the rotation of the nucleus, so that the corticocapsular adhesions are, and it's very easy to remove all this cortex and polish the posterior capsule, which is very, very important, because if you are left with some cells, then you will have the posterior capsular opacification, which when you do a YAG, there is a possibility of CME after that. And then you inject the IOL, and IOL I would not prefer to inject completely inside. I want to gradually insert it within the capsular bag and gently rotate it. And as you can see, despite the fact there is so much of manipulation, the lens being manipulated, there is no problem in these cuts which are there on the cornea. There is no problem of opening them. I never did myself anything more than 8 incision radial keratotomy in my life, which was almost 10 years. I might have done about 150,000 radial keratotomies. But these incisions are pretty strong once you have kind of taken almost 10 years or so. After that, there is no problem. These incisions do not give way. The only thing is, once you have manipulated so much, there will be some disturbance in the incisions, and these incisions will gradually heal once again and go to a little bit of hyperopic shift. So you have to take care of that while you are doing the cataract surgery. And then you hydrate you ascertain that the lens is situated or placed at the angle which you wanted. As you can appreciate here, the axis is correct, and once this is achieved, the procedure is over. Now the most difficult thing is IOL power calculation in all these cases, and this is what I thought that I'll talk about, because the rest of the thing is management of the lens and other things about the the phacoemulsification or femtolaser assisted cataract surgery. It's all very simple, but the IOL power calculation is basically a very difficult subject, and still one gets a hyperopic kind of IOL power after the thing, or sometimes there is a residual myopia. So there is still, you cannot pinpoint as to what is the problem in calculating, and majority of times it is because of the K reading which is not correct. So there are different relationships between LASIK, PRK and RK, and there is altered ratio between the anterior and posterior corneal curvature, which is the culprit for bad calculation. And there are so many formulas, the Barrett and the formula used in the corneal power in 2 ways. The corneal power is directly used in the Vergennes calculation, or corneal power is also used in the prediction of the lens position, effective lens position, as to what kind of distance between the cornea and posterior capsule you are looking at. This is very important, because whenever the corneal power is different, the flatter, it says the AC depth is also less and the lens is sitting forward. So these things are very important. There is an underestimation or overestimation of the effective lens position, which is very important. Radial keratotomy flattens both the anterior and posterior corneal surfaces, though there is not much of a difference in the anterior posterior corneal curvature relationship, but the problem is the small optical zone, which is what we have to measure. And in the RK, the posterior corneal surface undergoes a more evident flattening, and this causes overestimation of the corneal power, and IOL power is becoming on the hyperopic side. In the LASIK or PRK or SMILE or LASIK, whatever laser correction we are doing, the anterior corneal curvature is changed, and it does not change the posterior corneal curvature, thereby altering the normal anterior posterior curvature ratio, which is again very important, and one has to assess as to what kind of corneal curvature we are looking at, ultimately anterior and posterior both together. But the optical zone is much wider, so there is not much of an issue because of the calculation of the corneal curvature is not very difficult. So other thing is as I said, effective lens position, and this is actually the matter when you are calculating because of the curvature of the cornea, the effective lens position is erroneous in calculation, and this causes underestimation of the IOL power, and special methods are to be used. So there are many methods like clinical history, over refraction, topography based post LASIK adjustment, central ring topography and net corneal power measurement, and post laser correction. Most of the methods are accurate, give you reasonably accurate result, but post radial keratotomy these things are not so well understood and not so topography based post LASIK adjusted keratometry is not suitable for RK eyes, but you can do that with the formula which are present in the website, especially with the ASCRS formulas. And central ring topography, which is very, very important. What I follow is the Aramberry method, which is mentioned here, and one should go back and read the Aramberry system of calculating the radial corneal power after the refractive surgery, which gives mostly very, very accurate results, and these are very important. What I use is Pentacam. It is a method which gives you a very accurate calculation of the anterior and posterior corneal curvature, and then it gives you a very accurate corneal power. So post refractive surgery eyes, the double K formula or a true K formula, these two formulas are absolutely gives you bang on keratometry powers, and there you can kind of think of using them to get the corneal power correctly, and then use them as a true corneal power. So that is the best way to go forward. So double K formula is it's a very difficult thing to explain in 2 sentences, but at least go back and read Aramberry double K formula. This is a wonderful method. I'll just finish in 1 minute. So that is all. It is now considered the Barrett True K is considered one of the most reliable options for myopic and hyperopic PRK or LASIK, laser visual correction. So personal choice is on Pentacam, 3 mm zone, both vertical and horizontal axis, and anterior curvature plus posterior corneal curvature divided by 2, as I use as K. Thank you very much.
Thank you very much for Dr. Vati for with a beautiful insight of how to tackle the post-RK cases for cataract surgery. Thank you. So we'll have the discussion later. Our next speaker is Dr. Satanshu Mathur. Please be ready, Dr. Satanshu.
Dr. Satanshu.
Just 1 second, sir. Dr. Satanshu, we'll discuss, sir. Dr. Satanshu Mathur is a very renowned surgeon from Uttarakhand, and he's a very big hospital, and he's a very active member in the the Uttarakhand Ophthalmic Society, even AIOS also, and the North Zone Ophthalmic Society also. So he's going to talk on complex posterior polar cataract.
Thank you, Randall. Thank you all the organizers of this conference. So posterior polar cataract is an entity that is always a headache for the even for the specialist phacosurgeon. But if follow simple tips and tricks, we can achieve a high success rate even if there is a pre-existing break. So I am just showing the two videos. There are 8 tips and tricks. This is the preoperative evaluation is very important in posterior polar cataract because onion-like structures is there. You can see the rings. You have to differentiate it from the posterior subcapsular cataract, and you should keep in mind that in 33% cases of posterior polar cataract there is posterior capsule deficient. So always plan surgery with the vitrectomy ready. So this is how we can plan our surgery. Every procedure has to be very slow in such cases. All the rules should be followed. We should not make a shortcut. Dye, even if cataract is very soft, even then we should inject the dye to clearly see the margin because we have to make a small axis. And we are making an oval capsular axis. This is the first tip is the slit lab examination proper. Second tip is the oval capsular axis. Oval capsular axis always help. This is developed by Dr. Karanjit. This always help in removing the cortical matter in the superior part and also the nucleus manipulations. So oval capsular axis is really very important in such cases. But it should be small but adequate. And important tip is this. There is no hydrodissection. We are just cracking the nucleus in center without hydrodissection, as the nucleus is soft. And this is the important thing which I am going to show you. Now we are doing hydrodissection on the one side of see. So we have divided nucleus cracking, and then after cracking we are injecting the fluid inside this nucleus. The fluid will never go behind the cataract, never go to the posterior capsule. So this is the trick. The inject after the dilation in the division what we have made, and we can achieve the ring. You can see that we have achieved the ring. So it is very safe. Nothing is going to behind the posterior capsule. Tip 6, all parameters should be low. Second instrument is very important because we are manipulating the nucleus mechanically, lifting it, dividing it, because rotation is not advisable in such cases. So second instrument always very helpful. Nucleus are soft, can be easily manipulated. So just hold by the phaco. Then once you have achieved, important tip, AC should be maintained. We should never remove the main phaco probe without injecting viscoelastic from the side port. We should never allow the chamber to collapse. This is tip number 6. And now comes the irrigation aspiration. So bimanual always safe because it is very slow procedure. We are not to increase the pressure inside the eye. Bottle heights, etc. should be very low. So all the maneuvers, just pull it, radial pulling, bring in the center, and then raise. Again injecting viscoelastic before removing the instrument, and now doing IA from the other side. Because we always take chance of pre-existing capsular defect in such cases. So once you have done, then again injective viscoelastic, chamber is formed, and we can do. In short, so I am showing to other video. In short, this is the case after the surgery. This is another case where there is a pre-existing defect behind. We have seen on the slit lamp. So now we have to be more careful. Every procedure has to be gentle. Gentle hydrodissection is done. The cannula we are using, this is the cannula we are using. It has not the flow on the tip, but from the side. When there is a flow from the tip, it goes behind the posterior capsule. So it has side port. So when you inject the fluid, it will never go behind the posterior capsule. So this is hydrodissection with modified cannula. No fluid from the tip but from the side, and will never go behind the posterior capsule. It will remain inside the nuclear zone. So gentle hydrodissection is done, no hydrodissection. Now no cracking, just crack the nucleus. Do not rotate it. Crack it, crack it. Do not rotate the nucleus. because rotation will increase the posterior capsular defect. All the maneuvers should be gentle, bottle height should be low, phaco power should be low. Have patience while you are dealing with the posterior polar cataract instead of wasting time later on in managing the complications. And every anti-segment surgeon should keep a vitrectomy setup ready whenever they are dealing with the posterior polar cataract. You are not lucky every time to be 100% safe. So all the maneuvers should be gentle. Epinuclear shell is removed in the last because it protects the defect. Where the defect, epinuclear shell is there, so you remove it in the last, gently pulling it in from behind the anti-capsule into the center and then removing it. I'm just moving fast forward. So you see there is a defect in the posterior capsule. You can see there is a defect in the posterior capsule that was pre-existing, and by doing all this surgery this defect has not increased because we have taken all the precautions. So this is very important to take all the precautions. Even if there is a pre-existing defect, it will not increase and you can put the lens in the bag, whatever lens you want to push. Good. So vitreous space is intact. So thank you very much.
Excellent, Dr. Sudhanshu. And now we have a terminator with us, Dr. Rajendra Prasad from New Delhi. He is a very, very well-known innovator and invented so many things. Today is going to speak on while chopping when the cataract doesn't crack, what to do. Dr. Rajendra Prasad, over to you.
Thank you very much, Dr. Vinod, and good morning, everybody. And it's nice to see a lot of people in this early morning here in this session. And we have seen a lot of speakers, our eminent speakers have spoken already.
Meanwhile,
I'm just going to talk on a very, very hard cataract, rock hard cataract, how to manage these rock hard cataract when you don't get the crack in the hard cataract.
Meanwhile, we can have a question to Dr. Sudhang Bharti. Dr. Bharti, do you increase the energy while you are doing femtonoarchic cases?
No.
It's the same energy level?
It is the same energy level. I don't think we need to increase that actually increases the turbulence.
Okay. Yeah. Thank you. So over to you, Dr. Rajendra.
Okay. So we all come across these rock hard cataract in our clinical practice, and we know that there are a series of specific and difficult challenges when we deal with these hard cataract in terms of density of the nucleus, weak capsular bag, absence of the cortico-epinuclear buffer behind the nucleus. And the nucleus generally sits on the very fragile capsule, directly sits on, and then the chopping becomes very difficult. We use many techniques to deal with these hard cataract, but quite often when we try to chop these hard cataract, we don't get the crack in these lenses. And when you don't get the crack, then you are left with the undivided nucleus. What happened?
Okay. Okay.
It's opening other files actually.
Okay.
उनका हो गया
Is this the last one?
Sorry. Okay. So as you can see here, like many of these hard nuclei, you don't get the crack, and if you don't get the crack, then you are left with the undivided nucleus, and then the manipulation becomes too much because you have to taking out these pieces on the phaco probe becomes very difficult. So you have to use a lot of second instrument, and that is the time like you may get into the problem of capsule, cornea, and so many things. So I'll just take you through this very hard cataract, the simple management, what are the points you should remember when you're dealing with the hard cataract. Your pre-operative examination is very important because you should know that what is the case you are dealing with in your OT. And unless you see the case properly, because you have, in terms of the capsular status, pseudo-exfoliation, the hardness of the nucleus, the dilation of the pupil, all these points are very important because you have to have a very large dilated pupil, and during the surgery you must stain the capsule so that you get a large capsular axis, because always aim for the capsular axis of at least 5.5 to 6 millimeter in these cases, not less than that if you have to manipulate these hard nuclei. So what I'm trying to do here is I'm trying to get a 6 millimeter of pupil capsular axis, and your hydro procedures should be very limited. Don't use too much of the fluid. Don't inject too much of fluid. Many times there is an adhesion of the nucleus with the posterior capsule, and you may blow out the posterior capsule. Rotation of the nucleus is another important point. You must make sure that your nucleus is free in the capsular bag, because if you are doing the chopping, your nucleus has to be free. And then the important point is your chopper is also very important. I'll let you know about the chopper. And then you have a different techniques to use, because you can use a direct chop, you can use divide and conquer, and so many other techniques are there. What I'm going to show here is the terminal chop technique, which is very simple and very effective in these hard cataract. And as you can see here, because I'm trying to crack the nucleus from the equator, this is how you get a complete division of the nucleus into two pieces, as you can see here, because without too much of manipulation, you have it now two complete segment. Then you can hold the first segment and divide it further. But as you can see, because I'm going all around the equator of the nucleus, not the equator of the capsular bag, it is the equator of the nucleus, which is, I'll explain you a little later. And then you start the emulsification of the nucleus. And this is the second half, as you can see here, because hold it with the phaco probe, divide it into two, and then start the emulsification. So what I said was the most important is the cracker. The cracker is very important. What I'm going to show here is this is the terminator. We call it as terminator. As you can see, the shape of the terminator is a little different from the other choppers. It has a blunt tip. It's a round and blunt tip, because when you are hooking the nucleus, you are not hitting even if you hit the posterior capsule, it's not going to threaten the posterior capsule in any way. And then it has a wedge shaped. There is an inner wedge, internal wedge. As you can see here, internal wedge, like it's a wedge, it's like a chisel, not like a normal cracker, which is flat and sharp. It's a wedge cracker. And then when you use this wedge cracker, as you can see here in this, so just hold the nucleus at the center, and you have to go around the nucleus, just draw the nucleus around the nucleus, and when you bring it and you see the crack has already happened, you don't have to bring it to the center of the nucleus and don't have to cut the nucleus. You are just cracking the nucleus at the equator, and this crack actually, which happens at the equator, it transverses to the center, and you get a complete splitting of the nucleus, like if you have a block of glass block, if you crack it from the equator, you get a complete cracking. This is what happens with this cracker, and you can see these are another cases, and where you have a very, very hard nucleus. I'm just trying to hold it at just within the equator, just slightly draw it, go around, hook it, and then see the crack happens here at the equator. And then you have to slightly split it, and you get a complete cracking of the nucleus, full thickness cracking. This is another case, very, very hard nucleus. Just hold it. You have to look at the phaco probe where I'm keeping it. I'm not going very deep towards the posterior pole of the nucleus. It's slightly towards the equator. Hold it and then crack it here, and then split it. And when you split it, you get a complete two segments. And this is another case. You can see this is a grade 6, grade 7 nucleus, which is absolutely cataract nigra, which we call it. Otherwise, normally it becomes very difficult to cut, chop, or do anything with this cataract. Even making a trench becomes very difficult. But as you can see with this cracker, you can crack this kind of the nucleus also. You just held and you have splitted the nucleus into two. Now you are taking the first and see the division of the nucleus as if you have done a femto division of the nucleus, because you get a sharp cut. It's not a cut actually, it's just sharp crack. Any hard object, when you're cracking it, cracks into two completely. This is what is happening with this device. This will happen only with this device because it has a wedge, inner edge, and this wedge actually acts as a cracker, and you can complete the surgery in this kind of cataract. Otherwise normally you would require ECC or MSICS in these cases, but here with this device you can see like even this kind of the nucleus also you can crack, and you can emulsify very simply, and you can see the pristine clear cornea on the next day itself. And this is another case, very hard cataract. And look at the phaco probe. This is very important. The phaco probe you have to penetrate not towards the posterior pole, slightly towards the equator, then hold it, draw it a bit, and then crack here, because cracking has to happen at the equator only. Then only you get a complete splitting of the nucleus. This is another floating cataract, absolutely hard. Normally nothing will work in this way. You can't do horizontal chop or vertical chop in these cases, but here you can do the terminal chop technique. Just hold this from the center, go around it, and then crack it. You must be doing this technique many a times, but this is, if you use this device, then you can have a much better cracking of these nucleus also, and you can very simply complete the surgery. And this is, I'll just show you this animation, because you look at the position of the phaco probe. You are penetrating from the center and holding it at just within the equator, and this is, then once you hold it, slightly tilt it and draw it, then only, because you have to see the edge of the nucleus. Don't go blindly like we go in the horizontal chop. In horizontal chop we go blindly towards the equator and then you hit the posterior capsule. Here you don't go blindly, you have to draw the nucleus and see the edge, then only hook it. After seeing the nucleus, then hook it. This is what is happening, and then crack happens at the equator, and this crack, this is how you hook it, and then this crack goes to the periphery and you get a complete cracking. So thank you very much for the nice hearing. Thank you.
Thank you very much, Dr. Arvind. And we have another 3-4 minutes for a quick 1 or 2 questions if you want to have. Question to any of the panelists.
Yes. Very much, very interesting cases. And we have also in Egypt slots like this case is very high. So my question is, the chopper, does it have a special name for the chopper?
This is terminal chopper. Terminal chopper by Dr. Rajendra Prasad. You can ask, Epsilon is marketing it. Epsilon.
It's being marketed here. Yeah.
So you can just ask for the Terminator. This chopper name is Terminator. Yes.
Yep. Yes.
Use the mic.
Just wanted to know, the very hard cataracts, there's hardly any more space in the back for the nucleus. And if you have a patient which has got either exfoliation, big zonules, would this be the ideal technique to handle?
Yeah, definitely very, very good question actually, because as I said, whenever you're dealing with the hard cataract, the first and important thing is you must do a good examination of these cases. See, these all hard cataracts are not so simple. And if you have a pseudo-exfoliation, if you have a zonulolysis, if you have a weak zonules, if you have a phacodonasis, so all these cases you have to manage differently than nothing. Look, no horizontal, vertical or terminal chop. You have to manage them differently because you have to strengthen the capsular bag. You have to give a support to the capsular bag in terms of the capsular hooks and all these things. No, because then once you have stabilized, then you can use any technique. Very right, because as I said, again, the pre-operative examination is very important. You have to be sure, like the pseudo-exfoliation has created any weakness in the zonules, any weakness in the capsule. Corneal endothelium is, many of these cases with the pseudo-exfoliation, you have a low corneal endothelial cell count. Your anterior chamber would be a variable anterior chamber, because if the patient is sitting on the slit lamp, you will see the anterior chamber is shallow. The moment patient lies down, the anterior chamber becomes deeper. So you are sure like there is a laxity in the zonules. And if you have all these features of pseudo exfoliation in terms of zonular weakness and the capsular weakness, then you have to be very precautious, like you have to use capsular hooks, you have to have a very good dilated pupil, then in terms of you can use the pupil expanders, and your manipulation and your all the forces should not be diverted towards the zonules. You should work at the center of the nucleus so that you crack the nucleus at the center and then start the emulsification. So all these precautions you have to take. Yeah, that's right. Yeah. So if you have a pseudo-exfoliation glaucoma associated with the cataract, in that you have to decide like what is the stage of the glaucoma. You can go with the combined surgery also in these cases, or you can manage different separately. And secondly, with pseudo-exfoliation, very, very important point, as I said, pre-operative examination is very important. All pseudo-exfoliation patients have to be evaluated for the cardiac status also. Because many of these pseudo-exfoliation is a metabolic disorder actually happening in the patient, and it's the epithelial cell level deficiency of some enzyme which is leading to this. And these patients, if you have a pseudo-exfoliation, they have the skin also, they will have in the kidney also, they will have the exfoliation in the heart also. So these patients are more prone to have the cardiac disorder also.
So,
yeah, that's right.
Dr. Murray?
I would like to add something, because we had the opportunity of doing the first World Search clinical trial. So we compared this beautiful terminal chop technique, it's CTRI ICMR registered. The terminal chop technique versus the direct chop versus the stop and chop technique. So in the softer cataract, there was no significant difference. But when we talk about the grade 4 and grade 5 cataract, so effective phaco time, the cumulative dissipation of energy, it was much lesser in the terminal chop technique when we were dealing with the most hardest of the cataract. As well as, although there was no significant p-value difference in the endothelial cell loss, but it was lesser for the harder cataract in this terminal chop technique. Thank you.
Thank you very much. Dr. Arvind has done almost, I think, 2,000 to 3,000 terminal chop cases, and he is a professor in All India Medical Sciences of Bhubaneswar. He was in Hyderabad now, yeah. And he has done this work and published in a very renowned journal. And
yeah, it's a PubMed
yeah.
journal.
See, generally it's related to the aging of the patient, because the way the patient is aging more, they get the pseudo-exfoliation. But yeah, your dietary habit, your climate, your other factors, how you are maintaining your health, all these points are very important in pseudo-exfoliation. So thank you very much, and for the nicely being here with us, and thank you, Dr. Tamir, and because our special guest, Dr. Tamir, has given a very good talk here, and all the speakers, please come over, we'll have a good photograph here.
Come on,